Visual Feedback Training by Caitlin Brunn, Reggie Pamantuan, and Jillian Singson. Clinical Case Summary. Mr. M, a 41-year-old African American male, had a right CVA that occurred 4 years ago. The patient received 6 weeks of rehabilitation post-stroke and currently attends point labs provided by the University of St. Augustine. Patient currently utilizes a left posterior leaf AFO to assist with ambulation. The patient examination reveals a decreased strength of the left lower extremity, particularly with dorsiflexion and hip flexion, both 4 minus out of 5. There's also decreased strength of the left upper extremity with a significant step of 1.5 finger width at the left lateral shoulder joint due to left shoulder dislocation post-stroke. His abnormal gait pattern consists of diminished heel strike with left foot on initial contact, hyperextension of the left knee during mid-stance and pre-swing, circumduction and slight left hip drop of left lower extremity during swing phase, and no arm swing with left upper extremity during the entire gait sequence. The patient ambulated 1,257 feet, which is 383.13 meters, during the 6-minute walk test, outdoors on a flat and level terrain with the use of his left AFO. The patient performed single leg stance, left for 6 seconds, right for 30 seconds. During the left single leg stance, the patient needed upper extremity support with occasional foot tapping with right foot to maintain balance. Our PICO question. In patients post-stroke, does the use of visual feedback training compared to non-visual feedback training improve sitting, standing, and walking balance performance?
What is visual feedback training? Visual feedback training is a method that can be used to improve postural control by providing feedback on movements of body position through a reflection of the body image in a mirror or a visual system depicting the patient's center of pressure. The databases that were used were PubMed and Stroke Engine. The key words were visual feedback therapy, mirror therapy, stroke, gait, balance, and dynamic balance.
In 2017, Huang et al. Performed a random controlled trial where 20 patients post-stroke were divided into 2 groups, visual feedback training and unstable training. Both groups received conventional exercise therapy, which consisted of correcting abnormal posture and movements and promote normal exercise patterns through joint movement, stretching, and muscle strengthening exercise for 30 minutes twice a week for 4 weeks. The visual feedback training group also utilized the Balance Trainer 4 for 30 minutes 3 times a week for 4 weeks. The Unstable Surface Training group, on the other hand, utilized balance pads for 30 minutes 3 times a week for 4 weeks. They found that the visual feedback training group had decreased postural sway line from the center of pressure and trace length post-treatment, while the Unstable Surface Training group did not have any significant difference post-treatment. Both groups did show significant increase in the anterior, posterior, and medial lateral directions of sway range at the limit of stability post-treatment. But the visual feedback training group showed a great increase in the unstable surface training group. In other words, the patients were able to move farther from their base of support without losing balance. Therefore, based on the study, the utilization of a visual feedback for cueing with conventional therapy may be more beneficial for post-stroke patients than utilizing exercises with an unstable surface in conventional therapy. The flaws with this study was that it was a short-term exercise program that only lasted 4 weeks. In 2017, a cross-sectional study by Shin and Chung was done where 17 chronic stroke patients were asked to walk on a treadmill with random cueing. The cueing variations consist of visual feedback and rhythmic auditory cue, just visual feedback, and no cueing. The patients would walk 5 minutes for each trial and receive different cueing in random orders. For visual feedback, the patients were shown their step length as well as a target step length. 3 colors were shown on a TV to show where the patient was within their target step length. Green was 10 centimeters, blue 10 to 30 centimeters, and red more than 30 centimeters. Rhythmic auditory cues were given during initiation of the step cycle to adjust their step length. They found that visual feedback and rhythmic auditory cueing had significant improvement with step length and reduced spatial asymmetry on the affected side compared to the visual feedback alone and control group. Visual feedback alone showed significant improvement with step length compared to the control condition. Visual feedback and rhythmic auditory cueing showed significant increase in accuracy between the affected and unaffected sides compared to the visual feedback alone. Patients with visual feedback and rhythmic auditory cueing were able to increase their walk speed with spatiotemporal symmetry with walking. Flaws with this study consist of small sample size and the spatial difference as the only variables assessed with visual feedback and rhythmic auditory cueing.
In 2015, Ji and Kim performed a random controlled trial to examine the effects of mirror therapy on subacute stroke patients' gait ability. 34 patients were randomly assigned into two groups. The experimental group received mirror therapy and conventional rehab therapy for 45 minutes per day, which was 15 minutes of mirror therapy and 30 minutes of conventional therapy. The conventional therapy consisted of NDT facilitation. The control group received sham therapy and conventional therapy for 45 minutes per day. For the experimental group, the reflective mirror was facing the non-paretic leg. The exercises performed were hip, knee, ankle flexion, knee extension, ankle dorsiflexion, and knee flexion beyond 90 degrees. The control group performed the same exercises, but not in front of a reflective mirror. Both groups performed movements with only the non-paretic lower limb. The gait characteristics that were assessed were single stance, stance phase, step length, stride, swing phase, velocity, and cadence. Assessments were made before and after 4 weeks of therapy. The results showed significant improvements for single stance, step length, and stride in the experimental group compared to the control group. The experimental group had improvements in single stance, step length, stride length, swing phase, velocity, and step width compared to pre-intervention, and the control group had improvements in single stance, stride length, velocity, and step width compared to pre-intervention. So the study supports the hypothesis that mirror therapy would help with gait ability in stroke patients. It is suggested that a mirror provides visual feedback for successful performance for the affected limb when an exercise is performed on the non-affected limb. Visual feedback has been shown to be effective in proprioceptive senses and is closely related to maintenance of postures and balance, which is therefore clinically relevant to consider when focusing on dynamic balance and gait for stroke patients. There were limitations in the study, which includes the fact that there was a small sample size used, which means that these results cannot represent all stroke patients. Another limitation is that there was not a follow-up for this study in order to determine if long-term benefits were achieved by mirror therapy. In 2016, In et al. Performed a random controlled trial using virtual reality reflection therapy to investigate its effect on improving postural balance and gait ability in chronic stroke patients. 25 patients with chronic stroke were randomly divided into a virtual reality reflection group and a control group. Both groups performed a conventional rehab program for 30 minutes, and a VRT group also performed a virtual reality program for 30 minutes. This was done 5 times a week for 4 weeks. The conventional rehab program was patient-specific and consisted of NDT, physical therapy, occupational therapy, and speech therapy. In this study, patients in the VRT group placed their affected limb into a box, and then a camera was centered on the unaffected limb, and the image was projected in the location of the affected lower extremity. Patients then moved their unaffected lower extremity for ankle dorsiflexion and plantar flexion, forefoot and rear foot adduction and abduction, and hip adduction and abduction. The study used task-focused training to have patients complete these movements in order to move the different joints required for walking. This was done by having up and down buttons placed on the floor and having the patients tap the unaffected foot on the floor quickly. The changes in dynamic balance and gait ability were assessed before and after the intervention using the Berg Balance Scale, functional reach test, timed up and go, and static balance ability was assessed using a forced platform with sensors and with patients' eyes open and eyes closed. The results showed that there were significant improvements in the virtual reality reflection group compared to the control group for the Berg, functional reach test, tug, and postural sway, indicating a positive effect for this type of therapy on stroke patients' balance skills. By having the patients complete task-focused training with the virtual reality reflection to move the different joints required for walking, both gait velocity and cadence improved. This suggests that virtual reality reflection can be used to improve gait ability.
This next study by Lee K, Cho H, and Lee J from 2015 studied the influence of visual feedback training on the balance and walking in stroke patients. The purpose was to evaluate changes in balance ability of patients whose head positions were altered due to stroke. The design was an experimental study design. 42 patients with stroke post 3 months of onset were randomly assigned to either the visual feedback training group, the active range of motion training group, or the visual feedback training plus active range of motion training group. The VFT performed 4 sets of exercising using the Sensenect device, while the ART group performed 8 sets per session after cueing and education from a trained therapist. Finally, 4 sets of active range of motion exercises plus 2 sets of visual feedback training with a Sensenect device were used with the last combined group. The exercises for the VFT consisted of head movements following lines on a picture board with laser pointer. The ART consisted of cervical flexion extension, lateral flexion, and diagonal flexion extension movements. The VAT, the combination group, consisted of randomized sequences of the above exercises. The results of this study found significant differences in the total distance of the body center in the VFT group, significant differences in the training period, and significant differences with the main effect test, where the treatment period and interactions between groups showed significance via the 10-meter walk test. This implied that head adjustment training using visual feedback can improve balance ability and gait of stroke patients. Therefore, coordinating head and eye movements can be used to treat stroke patients. The final study used is by Pellegrino, Giannani, Marinelli, and Casiato of 2017, studying the effects of continuous visual feedback during balance training in chronic stroke survivors. Their purpose was to explore the extent at which sitting postural stability can be improved with cues to their center of pressure combined with continuous visual feedback of its position. The design is an experimental study design. 11 patients with chronic stroke were recruited and performed center of pressure training on a forced platform while receiving visual feedback of their current position. They were first trained to reach 3 different targets on the screen with their cursor by adjusting their weight on the platform. Conditions for testing their learned ability consisted of no visual feedback, different directions of targets, and different displacement amplitudes. The results of this study found that most stroke patients do not transfer the learned ability to the no visual feedback conditions. In fact, 3 subjects were only able to reduce the extent of error and directional error, whereas only 1 subject was able to generalize the learned ability to the different direction and different amplitude conditions. Therefore, overall, the stroke subjects displayed difficulty with applying the learned ability when the visual system was removed. This implies that the patients were not able to create an internal model of learning of the task and simply relied on the visual feedback system. For the sitting balance intervention, the patient will have a laser pointer on their head tracing vertical, horizontal, diagonal, figure 8, and oval lines, where they will do this for 4 sets for 3 minutes rest for 3 days per week. They will be NDT'd with verbal cues as to how they should return to neutral if they lose it.
Our next intervention will be to have the patient ambulate a total of 20 feet and step over a hurdle while walking towards a mirror. Patient will walk 10 feet on colored circles at step length and equal to opposite side. Once he reaches the hurdle, he will then be cued verbally and visually to clear the hurdle. Emphasis will be on balance of the stance limb. After stepping over the hurdle, the patient will then watch himself walk in the mirror for the last 10 feet. An aide should be providing standby assistance for safety. The patient will step over the hurdle 5 times, leading with the affected leg first, and then 5 times leading with the unaffected leg, cueing to focus on stability and activation of appropriate muscles for alignment. Progressions will be made with the height of the hurdle in 2-inch increments starting from 2 inches off the ground. Later progressions will consist of lateral stepping of the hurdle. Overall, future researchers should include long-term assessments in order to evaluate the long-term benefits of visual feedback training. Future researchers should examine the effects of long-term exercises, as visual feedback training might be effective for preventing falls in patients with stroke. There also should be future research on visual feedback and rhythmic auditory cues on temporal and kinematic variables in walking. More studies should also focus on providing the clinical significance of treadmill training that is applied with visual feedback training. There should also be further investigation on the effect of head movements on stability of the proximal portion of the body and coordination of the extremities. And finally, more studies are also needed to assess and compare the effects that visual feedback training has on acute, subacute, and chronic stroke patients.